my God, finally it's happening.
Jason, it's happening.
Right? The first inaugural podcast. The Breast Friends.
The Breast Friends. We
Whoa,
made it.
We made it. We made it. I mean, we've been talking about doing a podcast for such a long time.
And we need it.
We needed it. We did it. I mean, you are my brother from another mother. So this is fantastic. I always vibe when I'm with you. The chemistry we have is fantastic. So it's about time that
Jason,
we have our podcast.
This is going to be fun.
It is going to be fun.
Let's jump into it.
It is going to be fun. Let's jump into it. But I'm Jason Mouabbi. Those who don't know me, I'm going to be your best friend, oncologist, talking about breast cancer, joined by Paolo Tarantino. Take it away.
Super happy to join you in this. And what we want to do today for this first podcast of the Breast Friends is trying to recapitulate what has happened at San Antonio Breast Cancer Symposium.
Yep.
And this year, 2025, which I personally believe is going to be remembered for a long time.
What a year.
Quite a year, huh?
Yep, what a year. What a year. A lot have happened this year.
So we could start from many points, but I do think we are on the verge of a huge epic moment.
Yeah.
Because 20 years ago, basically, aromatase inhibitors changed the way we treat thousands, dozens of thousands, hundreds of thousands of patients with metastatic breast cancer in the adjuvant setting. And now, 20 years later, oral thirds are changing that again. We saw the first data at this conference from the lidERA phase 3 trial with a novel oral third, giredestrant, in the adjuvant setting, improving outcomes. So tell us about it, Jason. What did you think about it?
And you're right. I mean, this is fantastic. I want people listening to us to understand how fascinating it is to finally get something new that potentially has better side effect profile and will make our patient adhere more to their therapy than those decades-old medications that we've been using. I mean, remember, tamoxifen was approved in 1977, the first drug approved in oncology, and then the 90s bought the AIs, and then there was nothing until now. The lidERA study, what I really like about it is that it tackled it head on. So patient right away with intermediate to high risk could go and get randomized to either receive the oral SERD called giredestrant or go on endocrine therapy that's a standard of care, whether it's tamoxifen or an aromatase inhibitor. What's really surprising is that nobody anticipated that study to be positive.
I totally agree. Definitely not me.
Yes. Because why? Because in the metastatic setting, what happened, we saw that SERDs truly show activity in patients with ESR1 mutation, especially as single agents. So the idea here, you're bringing to the early setting, ESR1 mutation, like what is the probability of having ESR1 mutation?
0.5%
right?
or less.
Or less. So it's very rare. So we all felt that maybe it's not going to add an advantage over AI. Yet in a very short time frame, in 2.5 years to 3 years, we already see improvement of outcomes in a magnitude of close to 3%, and that is showing a hazard ratio of 0.7. Can you put that hazard ratio in perspective, Paolo, for us?
This was impressive, like 30% reduction in the risk of recurrence or death, comparable to CDK4/6 inhibitors, to ribociclib, to abemaciclib, which we know are highly effective agents, and we have long-term outcomes now, and we know they're effective in the long run. And so seeing that with a novel endocrine therapy kind of makes you think what will happen when we will combine all this. But before jumping into that, so what did you think of the toxicity profile? Do you think here we are escalating toxicity, de-escalating? What's happening there?
So what's fascinating about it, right before I talk about toxicity, is that if you remember when AIs, they said they were superior to tamoxifen, the hazard ratio was in the 0.8, 0.83, 0.85. And those were after many years, not after 2 to 3 years. Here, very early on, you're seeing a 0.7 hazard ratio, which is really exciting to see. But for the toxicity, you're totally right. What the metric I like is the discontinuation rate for the toxicities. If you look at the discontinuation because of arthralgia, which is usually the main issue that lead our patient to discontinue the aromatase inhibitors, when we look at the discontinuations because of arthralgia, there were a lot less on the giredestrant compared to the aromatase inhibitors, which is something that I'm really excited about our patient, because we all know in the metastatic setting, when our patient go from an AI to an oral SERD, they tell us the pain that they have in their joints goes away, which is something very exciting to see. And those drugs are better tolerated. I'm very excited for our patient. What do you think, Paolo?
Well, I think an interesting point was that it was conducted in a large population. This was stage 1, stage 2, stage 3, basically all patients with earlier to ER-positive breast cancer with some selection criteria, node positive or high biologic risk. But this suggests we're going to improve outcomes for a large population of patients. And the next big question, the hard one, which of course I'm going to ask to you, how do we combine this with adjuvant CDK4/6 inhibitors? Both ribociclib and abemaciclib are approved. Can we combine them with giredestrant? Would you, or would you wait for some more data?
Yeah. So you mentioned that if you look at, and the discussant of that presentation was very important, because if you look at right now at 2 to 3 years, at the magnitude of benefit, which is about 3%, with a hazard ratio of 0.7, is exactly the same as what we see with Natalie at that point in time, at 3 years. And Natalie, again, is the combination of a CDK4/6 inhibitor, ribociclib in that case, in combination with an aromatase inhibitor. So here, the question is with time, because we know that on those studies with CDK4/6 inhibitor, the more you go through time, the more that the benefit becomes better and better. Is that going to sustain as we go along, or we achieve the maximum benefit at this time? So definitely we need more time. But the other thing I would say, we need biomarkers. This is the time where we can go to all those companies. We need biomarkers to know who are the patient who should get a CDK4/6 inhibitor, who are the patient that we can forego CDK4/6 inhibitor and just give them single agent endocrine therapy.
Totally agree. The world of breast oncology changed with Oncotype DX, and I think we need a new change now. I don't know if it's going to be a tissue biomarker, blood-based biomarker, but we need those. But I think also now, we're learning in the adjuvant setting something that comes from the metastatic, because in general, oral SERDs have been first approved in metastatic setting. And so I would like to jump in this other disease setting where something else is happening, because we know that sometimes metastatic tumors can develop resistance mechanisms that are complex and require to be tackled with combination treatments. And I think one theme of this year, of 2025, was oral SERD combinations.
Yes.
What did we see this year, Jason?
So this is very exciting because oral SERD made that headway already in our field as single agents, and all of us, we were really wanting combination. We like combination in the US, so we're waiting for those combinations. So the first combination that we got earlier this year or late last year was the EMBER-3, when we looked at abemaciclib plus imlunestrant. And that was very encouraging. That was what we were expecting from the post-Monarch.
Right.
That was a better post-Monarch. You see something by continuing the CDK4/6 inhibitor, so using sequential CDK4/6 inhibitor in the second line, by changing the endocrine therapy backbone, you saw somewhere around between 9 to 11 months, depending whether or not you have an ESR1 mutation. Now, the exciting part is that the first drug that we used in that setting, the elacestrant, we had an update at San Antonio for the ELEVATE study. So we had an update with the 2 different combinations. The first one with another CDK4/6 inhibitor, abemaciclib, which shows, before I saw the data, I was guessing myself. I was like, okay, I want to put, what do I expect it to be? And I put between 9 to 10 months. No, it was an astonishing 14 months plus median PFS of using CDK4/6 inhibitor in the second line plus, which is something fascinating. 14 months, Paolo. What do you think about that number?
I think that's usually, what we start to see with cytotoxic treatments, ADCs, and in truth, we can get that also in the second line when you hit the right targets, when you use the right drugs. And I think it's relevant because we know that in the first line, endocrine therapy, CDK4/6 inhibitors work very well, sometimes for years. But it's really that second line window that has been challenging. In the past, only 5 years ago, we used to use a lot of fulvestrant, some everolimus, but in truth, it's never been active enough, what we had in the second line. This is changing. This is changing. And you mentioned already the imlunestrant abema data, the ELEVATE data with elacestrant. I was also impressed by giredestrant everolimus, the Evera trial that showed a doubling in PFS with adding giredestrant from 5 to 10 months. Very nice response rate. Most of the activity in patients with ESR1 mutations, but a hint of activity also in ESR1 wild type. And so let me ask you another hard question. Only hard questions for you today. Jason, brace yourself.
I love those questions.
So right now, would you consider oral SERDs, the approved ones or the coming ones, only for patients with ESR1 mutant metastatic disease or for the broader population?
That's a very good question, because another arm on the ELEVATE that was presented at this meeting was the elacestrant everolimus, which mimic the population on the Evera study that you just mentioned with the gerodestin everolimus. What's interesting in the Elevate study when they looked at the everolimus addition to elacestrant is that irrespective of an ESR1 mutation or a PIK3CA mutation, you saw a sustained activity and sustained median PFS around 8 months. Now, that we didn't see on the Evera. On the Evera, it seemed like the activity is only for the patient with ESR1 mutation. However, if you look at the patient with the ESR1 wild type, although there seemed not to be much benefit, the overall response rate was better. This is still puzzling. We need more data to do that. But what's exciting is that irrespective of ESR1 mutation, at least on the Elevate, you see that the combination is effective. That's super exciting. And that's why here we are, this podcast, we're going to be answering the hard questions. This is something interesting to see, and this is what we expect to see. The idea of doing combos is that hopefully they should work irrespective of a mutation. And that's exciting to see that we see that on both arms of the Evera, both arms of the Elevate that were presented. The other thing, I'm going to jump back 1 second for the abemaciclib arm. A big proportion of those patients receive prior fulvestrant. Yet, despite the prior fulvestrant, you still see a median PFS of 14 months. This is exciting.
This is exciting and important because we're starting to have several oral SERDs. And so the next big question will be, can we sequence oral SERDs? And I think most likely we will.
Yep.
And we'll figure out with real world data and with our experience how to do that in the best way. But I do think it's an exciting time in ER-positive disease.
It is exciting time. And now we're going to jump into another very, very, very exciting field.
Talking of exciting, exactly.
Yes, talking about TDXd taking over the world in HER2-positive disease. This year was full of exciting presentations. A lot of studies, pivotal studies have resulted. But let's focus a little bit about the metastatic setting first. With TDXd coming to the first line with the Destiny Breast 09. Paolo, you know the study very well. You're big in the ADC world. Take us through that study.
First of all, tell me something. So lidERA, we were not really expecting it to be positive, but did you have any doubt that the DB09 would be positive as a trial?
I had no doubt. I was just worried about toxicities, but I had no doubt.
I did too, did not as well. And we know that basically in HER2-positive metastatic breast cancer and early breast cancer, there is a pre-TDXd and a post-TDXd era. And we are fortunate enough to be in the post-TDXd era, and we're seeing astonishing activity in the pretreated setting. And now Destiny Breast 09 tested TDXd with or without pertuzumab, challenging a standard of care that has been around for basically a decade. The Cleopatra trial that had amazing PFS and OS curves really improved outcomes, but now we're seeing those outcomes improved again. So we have only seen the data with TDXd pertuzumab, and we've seen from the first line setting 40 months for 0 of progression-free survival. 40. And I look back to all trials, 40 months, what you had of overall survival in the past for HER2-positive metastatic breast cancer. How long the average patient survived, and now that's only how long the first-line treatment lasts. And now let's go to the other part of the equation, that is side effects. Because Cleopatra had this unique feature that we don't do often in oncology, that gave chemotherapy just for an induction period of 4 to 6 months, then dropping the chemo and giving maintenance HP. Whereas Destiny 09 tested the strategy of giving TDXd with or without pertuzumab for longer, until the patient tolerated. And personally, I think that's an opportunity of TDXd because it doesn't have cumulative neuropathy. So you can potentially give it for much longer. But at the same time, it's a challenge because we know that TDXd comes with chemotherapy-related side effects. And so we really don't know right now for how long we should give TDXd. So since we like hard questions, Jason, for how long should we give TDXd with or without pertuzumab in the first line?
This is a fascinating question. And let me just go back 1 second. For those of you that are still in their training or about to finish their fellowship, a 40-month median PFS, first line. It's not long ago, HER2-positive disease, like a few decades ago, HER2-positive disease had the worst outcome breast cancer ever. People, when they knew, doctors, when treating a patient and knew they were HER2-positive, their heart used to sink because they knew that the prognosis was going to be poor. And then we start having HER2-directed therapies. And now we're talking about 14 months median progression-free survival, meaning 50% of the patient do better than that 40. This is fascinating. This is fascinating, and this gives us fuel and fire because we want to take all cancer to that stage where we are right now in HER2-positive first-line metastatic disease. Now, you're right. A lot of people love the maintenance therapy, love to do the induction and then stop the induction therapy and go on to a maintenance that hopefully is less toxic and more tolerated for our patient. Now, I have to say, TDXd, in my experience, is very well tolerated. The idea is doing it for 40 months plus. That's a problem because eventually it's going to be tiring because the body has to deal with the payload at some point. The payload is a cytotoxic payload and the body has to deal with it and it's going to get hit by it. And that's why it gets tiring as you do it long term. Now, in the study for toxicities or other reason, they allowed patients to drop the TDXd and just continue the naked antibody, mainly like trastuzumab, and add continue the pertuzumab at that time. So that was done in 10% of the patients. All right, so we don't know how those patients did compared to the other one, but we'll see in the future. Oncology is still an art. I strongly believe us as oncologists, we will find a maintenance regimen for our patient, especially that maintenance therapies was another hot topic in this meeting and last meeting. So we have two studies here looking at very exciting maintenance therapies. The first one is in hormone positive, HER2 positive. We call them the triple positive breast cancer. And here we found very exciting data about a year ago with the patina. Can you let us know about the patina?
Oh yeah, it's so nice to see this maintenance setting within just 1 year between the prior San Antonio conference and this San Antonio conference, changing everything. Patina phase 3 trial. The question is simple. Is adding a CDK4/6 inhibitors, palbociclib, to maintenance, endocrine therapy, and HP beneficial? And I'm not sure of what we would have expected because we know that CDK4/6 inhibitors are highly active in HER2 negative disease, ER-positive, HER2 negative. In HER2 positive, we did have some trials like Monarch Hair, but nothing in the first line. And so this trial, when it read out last year, I think left many people with their jaws open, just surprised for the magnitude of benefit. In the control arm, just endocrine therapy, HP, led to a PFS in the maintenance setting of 29 months, to which you have to add the induction chemo.
100%.
So we're talking of over 30 months. But with adding palbociclib, the PFS led to 44 months, a median of 44 months plus the induction. Here we are really going beyond anything we could have hoped for this disease. And it's never enough. One would wish it to work forever, but 44 months plus induction, we're going basically to 4 years just for the first line.
4 years, 4 years. I mean, we're getting to a stage where we're going to start talking about curing HER2 positive metastatic breast cancer. I mean, can we dare say that? I mean, this is fascinating. That's the breast 09 show us 40 months plus, patina 44 months plus. I mean, this is something amazing.
It really is. But we know that patients with ER-positive, HER2-positive disease, triple positive, are just roughly half of the patients we see with HER2-positive disease. The other half, until now, didn't really have an announced maintenance option until we just saw HER2CLIMB-05. Jason, what did it show?
I mean, HER2CLIMB-05 is another step toward the future. It's also amazing. We're adding more exciting therapies. So here in the HER2CLIMB-05, we're adding tucatinib on top of the HP. So it's HP plus tucatinib as a maintenance therapy after induction. So on that study, the induction was 4 to 8 cycles of THP. Then you drop the taxane, which is the chemotherapy, and then you continue on maintenance HP and add tucatinib. What's really exciting is that the study was positive. And here we see close to 2 years median PFS on the addition of tucatinib to HP, which is really exciting to see this patient population. Not as high as the patina, because then it speaks a lot to the role of endocrine therapy in the hormone-positive disease and the heterogeneity of those cancers. You know, those cancers have two pathways that they can rely on. Blocking both really add a lot of meaningful improvement. In the pure HER2 positives, although the study did have patients who are also triple positive, and some of them also did get endocrine therapy on top of that, but no palbociclib, because at that time they didn't have the result of the patina. But it did improve outcomes by getting a median PFS close to 24 months. So the way I look at it is that in my triple positives, we have an excellent maintenance therapy with doing the patina trial. So doing HP adding palbociclib, and adding to it the endocrine therapy. And in the patient who are HER2 positive, hormone receptor negative, the HER2 is an excellent option for those patients by adding the tucatinib along. And also, the beauty about it is that now we don't have the final result about CNS PFS, but you can see patients who have baseline CNS disease, you can see an improvement of their PFS compared to the patient who took just HP, because we already know that tucatinib is very active in the brain. So that's another thing that's very exciting to see. What do you think about, so it is positive. Now, we know very well palbociclib and endocrine therapy, their side effects. What do you think about the addition of tucatinib in terms of adverse events? And what do you think that will play, how it's going to play out?
This is critical because I think, we are here escalating. We are adding drugs. And when you add drugs, the key aspect becomes managing the side effects of these drugs. And so I feel tucatinib in R2CLIMB-05 was well tolerated overall. It did add some side effects. The main side effect to watch out for is diarrhea.
Yeah.
And so even just in the control arm, pertuzumab, trastuzumab led to about 40% degree of diarrhea, mostly low grade. With tucatinib, it leads to about 60% diarrhea. Patients need to have loperamide available. They need to know how to utilize it. And I think that in most of the cases solves the issue.
Yes.
They have to be hydrated and all the things we know about how to manage diarrhea. The other aspect is liver function tests.
And that's the worrying one, to be honest to me.
I agree. And of course, it's one that the patients do not feel, but it can be troublesome. And so it's important to monitor liver function tests, to dose reduce when appropriate. And, we want these patients to be on these drugs for a long time.
Yeah, because honestly, I thought before I knew the result of the study, we know pertuzumab causes diarrhea. We know tucatinib can cause diarrhea. So I thought the number one discontinuation reason is going to be the diarrhea. I was shocked that the number one discontinuation reason was not the diarrhea. It was the liver toxicity, right? So that's something, because the whole idea of doing maintenance is you want less toxic regimen to go forward. And that's in the era of TDXd being in the first line plus pertuzumab. If you're going to do a maintenance, you want the maintenance to be better tolerated than the TDXd pertuzumab.
Fully agree.
So we really want to understand, is stopping TDXd plus pertuzumab to give a maintenance such as HP plus tucatinib really reduces a side effect and it's better tolerated for our patient? I don't know this answer today, but I can't wait to figure it out. What do you think, Paolo?
It's a great point. Since we're talking about toxicities, I think it's very relevant to mention that TDXd does have side effects mostly associated with chemotherapy, such as nausea, fatigue. But the number one side effect that is mentioned whenever you talk of TDXd, for a good reason, is interstitial lung disease.
Yep.
We know that about 10 to 15% of patients, depending on the trial, experience any grade interstitial lung disease. About 1% or less can experience fatal or life-threatening interstitial lung disease. So I think that's the number one side effect that you fear when you give this drug for a long time. We know that the median time of onset of ILD is about 5 to 6 months, but even after 1 year, you can see ILD.
Still.
So I think the benefit of this drug is undeniable. It's an extremely active drug, and this is why you want patients to stay on this drug and to capture ILD as early as possible, to stop the drug and give steroids. And to do so, patients need to be followed with CT scans of the chest every 6 to 9 weeks, ideally, in order to capture ILD when it's grade 1, asymptomatic, so that you stop the drug and give steroids.
No, that's a very good point. Catch it early. Coming to this, you published a paper about how to catch it, like survey for it and treat it. Can you go over those 5 features?
Yeah, this was a commentary to a review article, basically. And while I was writing it, I kind of realized that the 5 key points to remember how to manage interstitial lung disease basically all start with S. And the first one is screen. Screen meaning understanding the profile of the patient. If the patient has major lung or kidney comorbidities, both of them can raise the risk. If they had prior ILD, so understanding who you're treating and if it's a frail patient. In such patients, you may wanna be even more careful and scan very frequently. The second word is, of course, scan. Scanning patients every 6 to 9 weeks with CT scan of high resolution of the chest just extremely important, extremely important.
Yeah.
And then you have synergy with radiologists. Whenever there is any doubt of an ILD, review the scans with radiologists and pulmonologists, especially for symptomatic cases. We need their help to manage patients. The fourth S is steroids. It's fundamental to utilize steroids for these patients for any grade. And grade 1, you can think of 0.5 mg per kg of prednisone or equivalent, and 1 mg per kg for higher for grade 2 and 3. But in truth, a key point, I think, is the last S, that is stop.
Yep.
Or suspend. Whenever there is any suspect of an ILD, stop TDXd, do additional inquiries, exams to understand if there is an ILD, and give steroids. So the 5 S's, I hope, can help to memorize.
The 5 S's. People, remember the 5 S's. Really, really helpful in the day-to-day clinic. The last thing I like about TDXd to talk about is the issue about nausea. Now, the issue about nausea is one of the most prominent thing that the patient experience, especially that the drug half-life is long. It's about 5.5 days. So the 5 half-lives, that means that's when after 5 half-life is when we believe the drug becomes undetectable. So then side effects tend to go away at that time. But 5 half-lives of TDXd goes to a little bit over 25 days. So that's a long time. So you're going to have some delayed nausea. What I really like in my practice, and I feel like it's truly, truly experience changing and life changing of patients that go on TDXd, is the low dose olanzapine. Underutilized still in the US, massively changed the patient perception when they go on their drug. It truly becomes very well tolerated. What can you tell us about the low dose olanzapine, and do you use it in your practice?
So I do, and I feel that it's the only antiemetic that was tested in a randomized trial for TDXd. The ERICA trial in Japan showed that adding olanzapine can reduce the rate of emesis. And so I think it's important to remember that by NCCN guidelines, TDXd is a highly emetogenic regimen. So we always think of using 3-drug antiemetic regimens up front, just like a highly emetogenic. And adding olanzapine 2.5 milligrams in the evening can really, as you said, be dramatically helpful. And it's important to remember this. All of this that we're saying, ILD, nausea management, is becoming just so much more important now that the drug is about to move to the curative setting.
100%.
To the curative setting. And I think, all of what we do in the metastatic setting helps patients live longer, but then eventually there is this exciting moment when we take these drugs to the neoadjuvant and adjuvant setting, hoping to prevent recurrences and really eradicate the disease. And we've finally seen the data at ESMO this year, 2025, a year that will be remembered in time, of TDXd either before surgery or after surgery. What did we see, Jason?
I mean, these are impressive. These are 2 pivotal studies. We have the Destiny Breast 11 and the Destiny Breast 05. The Destiny Breast 11 is in the neoadjuvant setting. Now, the comparator is the European comparator, not the American comparator, which is dose-dense AC followed by THP, and it truly showed improvement of PAS CR. What's really interesting about that study, no ILD significant that it was reported when you do it for a short period of time before surgery. That's very exciting to see. The Destiny Breast 05, on the other hand, took patients with high-risk features. So high-risk feature. I want to say today on our podcast, this is not the Catherine study population. This is not the TDM1 population. Because there is a lot of confusion about that.
Exactly.
Some people think that the Destiny Breast 05 is here to take the same population of the Catherine study to give them TDXd instead of TDM1. It is not. It is not. It's even a more high-risk population that then go on to receive the standard of care, which is TDM1 or TDXd. And it also showed improvement of outcome. I mean, astonishingly, you're seeing way above 90% disease-free survival. I mean, this is very exciting to see. We're really doing a lot of goods for those patients by using those new agents. The one worrying aspect about it, however, was the ILD when you use it in the adjuvant setting. And there was some death reported to the ILD, which is a little bit concerning. That's why you have to select your high-risk patients. These are the ones that really need it, right? So what do you think about that, Paolo?
No, I totally agree. I think, the idea of 4 cycles of TDXd and 4 of THP, even for patients with high burden in a neoadjuvant setting, is highly appealing. There actually was slightly more ILD in the anthracyclines arm than in the TXd arm. So I think overall we feel that it's safe to give 4 cycles of TDXd and 4 of THP. It's highly active. The population of DB11 was mostly 90% node positive and mostly 75% or more receptor positive. It's hard to shrink these tumors, and to see over 60% PCR rates, I think is remarkable, especially now that we're starting to realize that carboplatin in this setting may not be as helpful as we were thinking. There is the NeoCar HP trial, for which I wrote the editorial, so little promotional moment. Make sure to read the editorial on JCO, and there's going to be some thoughts about how to implement all this. But I do think carbo may not be so helpful. It adds toxicity. In this setting, I think THP and TDXd will become a standard of care in the neoadjuvant setting for patients with higher burden. And then for patients with lower burden, we may get away potentially just with THP. And I think that will be a critical part of the future, figuring out which patients may get away just with THP. We need to see the data from RFS, from CompassAir PCR, which will be critical, a more than 2,000 patients trial. We need biomarkers. We need HER2-DX to be validated. We need to think about TILs and ctDNA and all of this, even imaging biomarkers. Doing an MRI during treatment can help, or maybe a PET scan. There's so much. We just need all of these things to collide in a pragmatic way to treat our patients depending on the anatomic risk and the biologic risk. And I think we're getting closer. What do you think?
We are. And for me, one biomarker that is going to be the future is circulating tumor DNA. I mean, ctDNA is truly emerging as one biomarker that's super exciting, not only as an MRD test that people think it is being used for, but also to better escalate and de-escalate neoadjuvant treatment. So that's something very exciting. But now it's my turn to ask you the tough questions. All right, DB11, DB05, what are you going to use TDXd? Are you going to use it neoadjuvantly, or are you going to wait and use it adjuvantly?
So we are here to address the tough questions and to provide our 2 cents, our opinions.
100%.
Because I think there is the data, but then you need to produce, a treatment recommendation based on those. I prefer neoadjuvant because it's a shorter course, because it's effective, because if you get the patient to PCR, you don't need any more cytotoxic treatment. So I prefer neoadjuvant for 4 cycles. And then if the patient has residual disease after neoadjuvant TDXd, our friend Jason is going to tell us how we treat these patients in the adjuvant setting.
So they call us the best friend for a reason. I agree with you. I would rather give it to them because then you're in charge of the situation in the neoadjuvant setting. So your patient, if they qualify for TDXd, you can give it to them. A lot of time when we go to the adjuvant setting, our patient might not be the perfect candidate anymore to receive it, and they might not get it, and they might not get a very important therapy that they need in their journey. Now, if they received it early on, what's going to happen in the adjuvant setting is a little bit more complex at this point. And it takes, again, the art of oncology to come. They say AI can replace doctors, that it cannot. It cannot for that reason, because there is a lot of data gaps out there that you need to use your own judgment as an oncologist treating the patient in front of you to see what you're going to do adjuvantly. We have a lot of options, thankfully. So thankfully, we have a lot of options. TDM1 is still a good option. TDXd, you can do it. We don't have data using TDXd after if you used it before, but it's going to be an option. Also, you can use HP, and there is a very important drug that I like, very underutilized in the US, neratinib. Neratinib is a fantastic drug. It reduces the chance of CNS recurrence. It also reduces extracranial disease. Very important drug. But I think this field is going to play out. But what's really reassuring, you talked to me one time about a poster that you saw, I believe, at ESMO, about using TDM1 after TDXd. And it showed activity of that agent after TDXd, which is something that's very interesting and very optimistic for me. What can you tell us about this?
Absolutely. I was lucky enough to be at ESMO Breast presenting a poster, and in front of me there was exactly the poster of what happened with TDM1 given after TDXd in Destiny Breast 03. So a large prospective trial. There were about 60 patients that received TDM1 after the TDXd, and what they saw is that TDM1 had the same activity that after TDXd than it had prior to TDXd. About 7 up to 8 months of duration of treatment, which I think is, in the metastatic setting is promising. But this tells us that when you switch the payload, actually you can retain activity
100%.
with ADCs. And so I do think for patients that receive TDXd prior in the neoadjuvant setting, considering TDM1 in the adjuvant setting, it's totally reasonable because it has a different payload. And I think this can help us to kind of transition, these complexities of ADCs, of their targets, their payload, can help us to transition to the last part of this podcast from today. And this is probably, the greatest unmet need in breast oncology, for which we are seeing finally some advancement. And this is triple-negative breast cancer, especially metastatic triple-negative breast cancer, a disease that if you look at real-world data is associated with less than 1 year overall survival in the real world. And in truth, there's been this class of drug, of which we started to talk already, that is kind of changing that. What can you tell us of the impact of ADCs in triple-negative disease?
Just a word about triple-negative. Really, I mean, the breakthrough we are doing in the other subtype of breast cancer, we are ready for a breakthrough moment in triple-negative breast cancer. I mean, our triple-negative breast cancer patients, especially in the metastatic setting, deserve better therapies. They deserve to achieve the same median PFS that we see now in HER2-positive disease of 40+ months. We are not there yet, but we want to get there. And I'm going to tell you right now, it's a promise from me, and I'm sure it's a promise from Paolo and every researcher around the country and in the world. You are not forgotten. We are working on it. We're going to get you there. We want to get for metastatic TNBC something like a median PFS of 40 months plus. Now, it's an incremental increase with time. Right now, where we are at least the ADCs are moving to the front line. This is key. And this is the first major step in improving the outcome of our metastatic triple-negative breast cancer patient. Few studies were presented at ESMO and before that at ASCO, looking at that first-line setting. So if you want to look at that first-line setting, looking, for example, in the patient who are PD-L1 positive, they looked at adding pembrolizumab to sacituzumab govitecan, which was something presented at ASCO 2025, and it showed improvement of outcome in that population when you do both the pembrolizumab in combination with sacituzumab govitecan. And then at ESMO, we saw 2 other studies come into play there. The Tropion Breast 02, which was the topotecan deruxtecan. And this one was presented for the patient who are PD-L1 negative, so CPS score less than 10%, as single agent without immunotherapy. And at the same meeting, the other TROP2 directed ADC was also presented in this similar population that is first-line PD-L1 negative using just sacituzumab govitecan. Both studies showed improvement of outcomes. But what I really applaud, I truly applaud the Tropion team that they allowed patients with a short disease-free interval. So those patients that were treated in the early setting who progressed quickly within 6 months were included on the Tropion Breast 02. Those patients were not included on the ASCENT study. And this is something big for me because triple-negative breast cancer is an aggressive histology. A lot of patients will reoccur early on. And those patients deserve to have the best of the best therapy as first line. So yes, we are improving outcomes. We are getting the right direction. We need more, but we're getting to that place. What do you have to add, Paolo?
I will just say, we are applauding this important choice to include patients relapsing immediately after adjuvant chemotherapy. On the other side, I would like to applaud also the ones that designed the ASCENT trials for building in the trial crossover. Because these are global trials. They're conducted in countries where ADCs are not available. Yep. And so you really want the sponsor to provide the ADC upon progression in patients in the control arm. And this was seen in both ASCENT trials. And I think it does kind of mix up the interpretation because whenever you allow extensive crossover, and in these trials there was about 80% crossover, so 80% of patients progressing on and receiving another line of treatment in the second line received an ADC, sacituzumab govitecan. This makes overall survival harder to interpret, but it does optimize outcomes for patients. And so the key outcomes here, I believe, to read are PFS, objective response rate, and probably the thing that differs the most between the two ADCs, SG and Dato-DXd, toxicity profile. So
Yep.
let's briefly touch on that, and let's see if that can help us to choose which ADC to use for these patients. What do you think?
Yeah, no, 100%. So AG, we've been using it for a while. So sacituzumab govitecan has been used for a while. And we know that the main issue with that drug is the neutropenia. Now, that's why in my practice, at least, what I do is I prophylax with GCSF early on. You know, I do a short-acting GCSF, one dose after the first infusion, and I do the long-acting after the second infusion, really help with that. The beauty about the other drug, the beauty about the topotecan deruxtecan is that neutropenia is not really the problem there. So that's why it's encouraging, because then you can do combinations. That's why it's encouraging about that. But you see a different side effect profile that also can be very well controlled. But these are something new that it might take a learning curve. Thankfully, right now, I feel much more comfortable dealing with it. And that's we're talking about the ocular toxicity when it comes to the topotecan deruxtecan. That's one. The other one is the stomatitis. Thankfully, the stomatitis, if you do a steroid mouthwash, you can really control it. Prophylaxis is key. Prevention is key. Once it happened, you're going to treat it. You're already trying to play catch up. It might not be very beneficial at that time. But if you try to prevent from the beginning, it really helps. Ocular toxicity, I can tell you. I mean, I know they say send them to an ophthalmologist, send them to an optometrist. There is a list of stuff you want to do and all that. Let me tell you, after using it in the metastatic hormone receptor positive, I feel very comfortable taking care of that. It's a surface issue. It's not a structural problem with the eye. You give them some artificial tears, they do fine. So the more you use it, the more you feel like, it's okay. It's not that bad. What do you think?
Now, I do think that this toxicity part is what helps the most to choose which drug to use in which patient. And this is why I think in this place, having options means trying to integrate them with patients' preferences and clinical profile. And in this setting, there may be patients, for instance, that prefer the 3-weekly schedule of Dato-DXd that is convenient and may accept some ocular toxicity that, as you said, is mostly dry eye,
Yeah.
and can in artificial tears can help for that. Avoiding contact lenses is important.
Oh, big. Avoid contact lenses with those drugs.
Exactly. RSG, that has a more intensive schedule, day 1, day 8.
Yep.
It has some neutropenia, needs growth factors, but we know we have some more confidence with it because it's been around since 2019, basically. Yep. But overall, I think all of this becomes even more critical. We have seen how TDXd has moved to the early stage setting.
Yep.
And has dramatically improved outcomes. What's going to happen now that these TROP2 ADCs, SG and Dato-DXd, another newcomer TROP2 ADC, sacituzumab tirumotecan or sac-TMT, will move to the early setting, and there are phase 3 trials ongoing. Can we try to guess what's going to happen in the near future?
Yeah, so in the near future, we're going to need better agents and newer agents and become creative. Some stuff that are exciting. And by the way, this is a podcast. We're going to have lots of episodes. We're going to talk about those. One of the episodes I want to do is the future of ADCs, the future of immunotherapies. But we are getting newer agents. We are getting newer immunotherapies, like the bispecific immunotherapies. Those, for example, that target PD-1 and VEGF. We are getting new ADCs. So you are getting ADCs with either the ADC that can target multiple targets or an ADC with multiple payloads.
That's so exciting.
I mean, these are very exciting, and we're going to have all of those coming to you. I mean, let me tell you, this is a historic moment, Paolo. This is a historic moment. This is the end of our first podcast, our pilot podcast episode.
I'm so glad we made this
amazing.
happen, and I think it's going to be the first of many episodes.
It's going to be the first
There's
of
a
many.
lot of questions to address, a lot of things happening. I think of these TROP2 ADCs moving to a neoadjuvant and adjuvant settings, curing more patients with triple-negative disease, avoiding metastasis. I'm very confident, especially of the residual disease trials. We are using still adjuvant capecitabine based on Curative, a trial conducted in Asia, which showed improved in outcomes. But I think we feel confident that we can definitely further improve outcomes there. Dramatic risk in residual disease triple-negative. ADCs, I feel, will help there. They will bring side effects. This is why we always need to remember about these side effects and how to manage them.
For sure.
But I think the future is bright.
The future is bright. And what I want to leave you with today at the end of our podcast is a few things. This podcast is going to be a very friendly way to discuss the pivotal research in the field, the tough question. We can answer the tough question. Listen, this is not CME, so we're going to be answering the tough question. We're going to tell you about our practices, how we do it between me and Paolo. And we'll get a chance also to get some speakers to come join us, invite some speakers with us, especially when we discuss big publications. And you can expect from us to go into granular details about those studies, explain them in a very nice way, and be your companion in your busy clinic, maybe on your ride home, maybe when you want to listen to some friendly voices talking about some diseases that you want to get to know more about and some treatment you want to get to more about. So this is going to be a great collaboration between us and you. What do you think, Paolo?
Jason, I always learn from you, but most important, I always have fun with you.
Yes.
Let's make this happen.
Yep, we are going to do it. Thank you all for joining us, the Breast Friends. And please follow us. Don't forget to subscribe and follow us on your favorite platform. Thank you so much.
Ciao.